Hello friends, welcome back to my channel Medicine Hub 101. Today we will talk about endometriosis. So it's one of the important topic regarding gynecology. Okay. So before starting the topic in details, let's define the term endometriosis. Okay. Now see, normally what do you know? Normally during the normal menstrual cycle, as we know that the estrogen that will help to proliferate the endometrium. Okay. And the progesterone that will just cause the setting off of the what endometrial gland, these regions. After that we will get the menstrual bleeding or the bleeding phase. The progesterone that will cause the setting of this uterine endometrium regions, and will get the bleeding under normal circumstances. Now sometimes, okay, normally we get, let me show over here the bleeding part. It is coming out in these regions. Now see, endometriosis, we can define this term by writing that we'll get to see over here the retrograde menses. Retrograde menses. What do we mean by retrograde? Retrograde means in the opposite direction. That means the menstrual bleeding is supposed to come in these directions from the uterine cavity through the vaginal openings. It is supposed to come outside, but in these cases, we'll get to see the bleeding. The menses that will go in these directions, and that can be accumulated within the ovary. We can also get to see the bleeding wire within the ligaments, also within the bowels. So let me write the name of these regions. So we can get to see within the ligament, within the ovary, in the bowel, in the bowel. Now, near about 70 to 80%, what did I say? 70 to 80% of all women are having the retrograde menses. So what did I say? Near about 70 to 80%, 70 to 80% of all women are having what? The retrograde menses. But among them, only 5 to 10% of the women are having the endometriosis. So 5 to 10% of women among them are having endometriosis. Now see, try to understand from here the basic things. So normally what do you know? The endometrial gland that is supposed to be located where? Within the endometrial regions, right within the uterine cavity. Now if we get to see that the same kind of the endometrial glands that is locating other than the uterine cavity, for example, the first most common site, as we know, the most common site where of the endometrial within the uterus, then is the first most common site. Second most common site we can get to see where? Within the ovary, right? Basically, we can see it over in terms of pouch of Douglas. Pouch of Douglas in these regions, and we can get to also see within the sometimes you can get also see within that ligament regions and the bowels also as well. So you can write down over here the bowel regions. Within the bowel, you can also get to see the most common site, that is the uterus. Then the second most common site is the ovary, and the other sites you can get in terms of the bowels, in terms of the ligaments, something like this. Now, what type of the problem we'll get to see over here? The main thing is over here that whenever we get to see the endometrial glands in these particular regions, by the same actions of the estrogens in those particular organs, there will be also proliferation of the endometrial gland, and by the same actions of the progesterone, we'll also get to see the bleeding in these regions also. That means we'll get the periodic bleedings in those particular regions, right? Now basically, this endometriosis most commonly seen in third to fourth decade of the woman. Third to fourth decade. That means near about 25 to 35 years. In this age group we can get to see, right? Now why we will get to see the only 5 to 10% of the women will have only the endometriosis? There's two reasons. The first reason is over here, that the low immunity power, or you can say the poor immunity, and the second most reason is estrogenicity. That means if we get to see in any woman, she is having poor immunity. Okay, that means the immunity that is less, and a hyper estrogenicity, for example. In those particular women, we'll get to see the the endometriosis. In those particular women, we'll get to see the endometriosis. Now, whenever the estrogen that will be more, As a result, we'll get to see the more proliferation, right? And see, what did I say? Why did I say that the poor immunity? Normally, the endometrial gland is supposed to be located within the uterine cavity, but whenever this will be located outside the uterine cavity, for example, within the ovary, within the ligament, within the bowel, our immune systems that can recognize that this endometrial gland that is not supposed to be over there. This is supposed to be where? Within the uterine cavity. This is not supposed to be other than the uterine cavity. So our immune system that can recognize it and that can destroy those particles or those particular regions where the endometrial glands will be located. But if any woman is having the poor immunity, the the immune systems, the defense system that will be not that much stronger. For example, over here, so that's why I have written over here what the poor immunity. So in those particular regions, we'll get to see the periodic bleeding. Now, the most dangerous conditions we'll get to see over here, that through the venous route or through the bloodstream, sometimes we get to see that the the endometrial glands, they can also go where? We can get to see within the lungs, within the nose, within the eye. Now if you get to see that endometrial glands, they are located also within the lungs, within the nose, within the eye, by the same actions or in the same process, or under the influence of estrogen and the progesterone, we'll also get to see the periodic bleedings within the lungs, within the nose, within the eye. Now, whenever we get to see the bleeding, periodic bleedings within the lungs, that will cause the hemoptysis. Whenever we get to see that bleeding within the nose, that will cause the epistaxis. Whenever we get to see that bleeding within the eye, that will cause the subconjunctival hemorrhage. So, what did I say? In these cases, we'll get hemoptysis. In these cases, we'll get to see the epistaxis. And in these cases, we'll get to see subconjunctival hemorrhage. Okay, and together these three things is known as vigorous. Let me use the different color for it. Okay, let's use this one. So these three things together, they are known as vigorous menses. Okay, it's one of the potential questions that was frequently asked in NITPG and INICT as well as in the FMG exam. Okay. Now, on the histopathological examinations, how can we recognize or identify the vigorous menses? Okay. For example, try to understand from here. See, in these cases, we'll get to see that deposition or deposit form. Or, for example, if we get to see these things, try to understand. Okay. Anyway, now for example, is the ovary. Now within the ovary, whenever we get to see the bleeding, okay, whenever we get to see the periodic bleedings for long time, as a result, we will get to see this bleeding, the accumulated blood, right? That will be that the RBC that will be broken down, and that will produce the bilirubin, and ultimately we'll get to see the ovary that will be looking like chocolate cyst. So that's why it is known as chocolate cyst ovary. So these are the pathological findings we can get over here, okay, which we can understand, yes, the woman is having endometriosis. Now, another thing we'll get to see over here, that is known as powder burn lesions. We'll get some blackish spot over here, that is known as powder burn lesions, okay. Now let's go to the pathophysiology part. Now whatever thing we'll get in the pathophysiological conditions. For that thing, let's take this part over here. So I'll just draw the three different diagrams from where it will be easier to understand the whole concept. So normally, for example, it's the uterine cavity. Now, as we know, the endometrial gland is over here. The endometrial gland is over here. And this fallopian tube and the ovary is over here. Now, for example, what did I say you? That whenever the secretory phase will come by the actions of the what? By the actions of the progesterone, okay? And after ovulations, we'll get to see the setting off of the endometrium, and we'll get to see the bleeding that will come through the vaginal opening over here. Now, for example, there is also what? We're also getting the endometrial, gland that is located, for example, in these regions within the ligament portions. In the same way, what did I say you? That in the same way, this part or this endometrial gland part that is located within the ligament, that will be acted also by the what? Estrogen as well as by the progesterone. Now we'll also get to see that what? Bleeding over here, right? The periodic bleedings. But in these cases, by the contractions of the uterine cavity, the blood that will come out through the vagina. Okay. So we'll get to see the menstrual bleeding over here, that will come out. But what about this one? In these cases, the blood that will be not able to come out, that will be deposited over here, okay. And whenever we get to see the periodic bleedings again and again, and that will be deposited over here, that will stress the peritoneum. That will stress the peritoneum. So what did I say you? This will stress the peritoneum. And whenever the peritoneum that will be stressed, we'll get to see the severe pain. In these conditions, we'll get to see the severe pain. So what did I say you? That the normal endometrial glands are present over here within the uterine cavity. So during normal menstrual cycles, the bleeding, during the bleeding phase, the blood that will come out by the contractions of the uterus. But in the same way, if we get to see that endometrial glands like structure that is present where within the ligament, for example, over here. But this bleeding, after the bleeding phase, the blood that will be not able to come out. As a result, we will get the depositions of the blood or accumulations of the blood within these regions, and that will cause the stretching of the peritoneum. That will cause the severe, severe pain. The next phase, what type of thing we'll get to see, that whenever we get to see this type of the things, abnormal things over here, our immune system that will be activated. So we'll get to see the macrophage, the neutrophage, the antibodies that will come over here. Okay. So what type of things we'll get over here? Let's draw it over in this part. So again is the uterine cavity. Endometrial gland, where the endometrial gland, and in this part where the fallopian tube is the ovary. And I said in these portions we got the accumulated blood. So whenever we got the accumulated blood over here, for example, and as I said you, we'll get to see the different systems of our body, the different kinds of the antibodies, different kinds of the WBC cells, they will come over here. And after that, whatever thing we'll get to see, ultimately we'll get to see the what is scarring formation, we'll get the adhesions, So the main thing over here, we'll get the adhesions, we'll get to see the scar formation, scarring, okay, and ultimately we'll get the fibrosis. So whenever we get to see the adhesion, that means that will be able to adhere any what? That will be adhere any, for example, any part. In the same way, whenever we'll get to see the adhering property in these regions, what type of changes we'll get to see? Let's talk about that thing in this part. So this is the again uterine cavity. This is the endometrial lining. The endometrial lining. Now is it was the fallopian tube. In the same way, whenever we will get to see the adhering nature in this part, try to understand from here. This will cause the adhering of the fallopian tube. That means the fallopian tube, for example, that will be located in these directions. Let me show the fallopian tube with the different color. So the fallopian tube that will be adhered by this combination, that means the adhesions or the skirting of the fibrosis process. So ultimately, see, whenever this part that will come downwards, so the ovary will be over here, of course, but there will be no attachment of the ovary along with the fallopian tube. So the ovary, during the LA surge, it will release the ovum, but this ovum, normally what do you know? Normally the ovum that will be caught up by the fimbri of the fallopian tube, but in this case the fimbri, so I should say of course that the whole fallopian tube that will be adhered downward in these regions, so there will be no fimbri to take the released ovum that is released by the ovary, so there will be no fertilizations. That's one of the most common complications. So in these cases we'll get the infertility. So what did I say? Let's revise once again. So see, in these cases, as first I said that whenever we get to see the endometrial gland that will be located apart from from the endometrial glands, that means outside the intrauterine cavity. For example, we got the endometrial gland is over here. So by the actions of the estrogens and the progesterone, we will also get to see the bleeding over here. Now whenever we get to see the bleeding over here, the accumulated blood that will stretch the peritoneum, that will cause the pain. Okay, so whenever the accumulated blood over here will get to see, our defense system that will be activated. Okay, so different kinds of the antibodies and the WBC cells, they will come over here. Ultimately, we will get to see the adhesions, the scarring formations, or the fibrosis. And by the adhesions natures of these particular regions, they will be able to adhere the fallopian tube, the whole structures of the fallopian tube downwards. Now, whenever the fallopian tube that will be taken downward, so there will be no attachments along with the ovary with the fallopian tube. So whenever it will be adhered downward, okay, it will be taken downward, there will be no attachment in between the ovary and the fallopian tube. So during the LH surge process, as we know, there will be ovulations, but this ovum that will be not taken by the fimbri, because the fimbri is not in the right positions, right? So there will be the chances for the infertility that will be increased. Hope you understood, right? So let's talk about in terms of the diagnosis. So how can you diagnose the endometriosis? So for the diagnosis, we can use the ultrasonography, we can use the MRI. Apart from that, we can use CA on 25, the cancer antigens on 25, just to rule out the endometrial cancers or the carcinoma. Or the best diagnosis we can do by laparoscopy. With the laparoscopy. Now let's talk about the clinical manifestations. So what type of the clinical features we'll get to see in these conditions. Okay. So in terms of the clinical manifestations, the first thing we'll get to see that pain, the chronic pain. We'll get to see the chronic pain, right? So this chronic pain, basically we'll get monthly during the periodic times, and that will be severe. severe. Apart from that, whatever the other manifestations we'll get, see, we'll get to see over here the dyspareunia. That means the deep pain. Dyspareunia means the deep pain during intercourse. During intercourse. The third thing we'll get to see over here, that the frequency of the intercourse that will be reduced. The frequency of the intercourse that will be reduced. See, whenever we'll get to see the deep pain during intercourse, of course the the individuals they will not be intended to have the intercourse. That's why the frequency of the intercourse that will be reduced over here. And of course I have said over here one of the most we can say also in terms of the clinical manifestations. So we will get the infertility over here. Infertility. And the most important on that we'll get over here, there's the embryo toxicity. So we'll get to see the embryo toxicity. How can we get the embryo toxicity? For example, try to understand. With the uterine cavity, we got everything over here. So is the what? Endometrial glands we are getting over here, right? Is the uterine cavity. For example, we got the implantations over here. But the problem is over here. Whenever we, as we discussed over here, in these cases, we'll get to see the presence of the endometrial glands will get other than the what? Uterine cavity or the endometrium of the uterus. So from the other regions of the endometrial glands, for example, from the ovary or from the other regions where it is located, from here we'll get the secretions of the different kinds of the cytokines or the interleukins, right? So we'll get to see the different kinds of the interleukin and cytokines, and the different kinds of the interleukin and the cytokines, they will not let the embryo to develop properly, so they will just cause the interference in the development of the embryo. That's why we'll get to see over here also the embryo toxicity. And even if we get that, the embryo will get the poor quality embryo, and in these cases the chance of abortion that will be increased. In these cases the chance of abortion that will be increased too much. Okay, now let's talk about the treatment part. So we can do the two types of the treatment, surgically and medically. So in the surgical treatments, okay, basically in this case, in terms of the endometriosis, we should prefer the medical management, okay, rather than the surgical management. Okay, let's go on by one. First we will go to the surgical management, then we will go to the medical management. Okay. Okay. So let's go to the part over here. See, so the first thing for the management, we'll go for the surgical management. So surgical management, we can go for C. As we are getting over here in this case, see, as I said, we are getting the adhesive molecules. So we can go for the what? Adhesional lysis. Another thing, see over here, we are getting within the ovary, we are getting what? The ovary is looking like what? As I said over here, that chocolate cyst ovary. So we can go for the cystectomy. In terms of the ovary over here. So surgical, we can go for, just to remove the adhesive molecules, we can go for the adhesive, and we can also go for, what did I say, cystectomy. And as we will also get over here the different kinds of the deposit, let me show over here the different kinds of the elementary things we'll get over here. We can say the deposits within the uterine cavity. So just to remove the deposits, we cannot go for the surgery, because if we want to remove the deposits from the whole uterus, we have to go for the hysterectomy. We have to remove the whole uterus part, but that's not the preferred treatment. Just to remove the deposits, we can go for the laser treatment or we can go for the ablations. Okay. Okay, let's write it over here. For the deposits, blue deposit, as I said over here, this part I have already explained this part, that in terms of the histopathological examinations. So just to remove the deposits, we can go for the two ways. Once we can go for laser treatment. Okay. So, and we can go for the thermal method also. By using these two methods, we can just remove the deposit from there. Okay. Now let's go for the medical management. Thing is, try to think one thing, that whenever we will use a surgical method over here, for example, we have by the process of cystectomy, we have removed the cyst from the ovary. But there is the most common complications we'll get over here. That's the recurrence. That's the recurrence. In most of the cases, in terms of the surgical methods, we can get the recurrence of the endometriosis. So just to avoid that or recurrence, we have to go for the medical management. Okay, let's go for the medical management. That was the surgical management. Now is the medical management. Now medical management, why you should go for the medical management? We will go for the medical management because in the surgical methods and the surgical management, we can get 60 to 70% recurrence. 60 to 70% recurrence. So the first line drugs we can use over here. That's the injections of the DMP. Normoproxy, progesterone acetate. Normoproxy, progesterone acetate injection. So we can just inject this one for 150 mg per 3 months. That means within 3 months we have to give one times what? That's the DMP injections for 150 milligram. Okay. Now what it will do? What's the mechanism of actions for it? In these cases, basically we are using this term progesterone. So the progesterone, that will be too much. The progesterone will be so much, and this progesterone that will stabilize the endometrium. This progesterone that will stabilize the endometrium. Stabilize the endometrium, and it will also inhibit the secretion of estrogen. So estrogen that will be less secreted. So whenever the less amount of the estrogen that will be secreted, so try to understand. So there will be no ovulations, there will be no menses, so there will be no bleeding, so there will be no pain. So the chances for the endometriosis that will be also less over here. Recurrence, right? So what did I say? The injections for the DMP over here, that will contain more amount of the progesterones, and the more amount of the progesterone that will stabilize the what? That will stabilize the, see over here, the endometrial all over here, the glandular structures. And whenever it will be stabilized, along with that the estrogen that will be less over here also, so we will not get the settings of these portions. That means we can also say that the endometrial glands, the size, the proliferations of the endometrial gland, that will be also less. Okay, the proliferation of the endometrial gland, that will be also less. So whenever the estrogen that will be less, just like this. So continually if we give the DMP injections, okay, so one time will come when we will get to see the estrogen that will be so less that there will be no bleeding. There will be no bleeding. Okay. So on we can go for that DMP injections. Another drug is over here, that is known as danazol. Danazol. Now danazol is having the what? Androgenic properties. Androgenic properties. So whenever it is having the androgenic properties, rather you can say it is having anti-estrogenic property. Anti-estrogenic property. So it will not let the estrogens to secrete, sufficiently, or you can say over here that the functions of the estrogen that will be inhibited by the action of danazol. But danazol is having some side effect. Okay. So what are the side effects? We'll get clitomegaly. Maybe 1 to 2 centimeter of the clitoris will get the enlargement of the clitoris, and it will be looking like small penis also. Now second thing we can get over here, there's the hysterisms. Third thing we'll get the hoarseness of the voice. Hoarseness of the voice, just like the man. And this is the first symptom. Whenever we'll get to see the hoarseness of the voice, instantly you have to stop the drug. So this is the first sign and symptom to stop the danazol, or you can go for the removal of the danazol therapy over here. The pharmacological therapy of the danazol, that should be stopped in these cases. Okay. But